Good morning everyone and welcome to this meeting of the Health Scrutiny Subcommittee. Apologies for starting just a few minutes late this morning. Can I please request that mobile telephones and other equipment is switched to silent mode so as not to disturb the conduct of the meeting. There's no fire test planned for today. If there is an emergency evacuation, please take instruction from Town Hall staff and the assembly point is Tudor Square. If I can ask members of the committee to introduce themselves. So I'm Councillor Ruth Milsom, Chair of this committee, and we'll pass round in this direction, Lucy.
I'm Lucy Davis, Chief Officer of Health Watch Sheffield.
Councillor Steve Harris, Deputy Chair of the Health Scrutiny Committee.
I'm Councillor Kevin Oxley from Hosborough.
Dr Josh Meek, I'm a GP at Firth Park Surgery and also the Clinical Director of the Foundry Primary Care Network.
Hi, I'm Jackie Mills, I'm Chief Finance Officer for Sheffield as part of the South Yorkshire Integrated Care Board.
Hi everyone, I'm Lucy Ettridge, Deputy Director of Communications and Engagement and Equality for NHS South Yorkshire.
Councillor Abdesam Mohammed, Firth Park Ward.
Councillor Mary Lee, Darnell Ward.
Councillor Martin Phipps, City Ward and Green spokesperson.
Hi, I'm Jenny Skeeber from Democratic Services, just to take the minute.
Hi, I'm Emily Stanbrook-Shaw, Policy and Improvement Officer.
And Sarah Bennett, Assistant Director of Legal and Governance.
Thank you very much everyone, thanks for coming this morning and also welcome to members of the public who have come to ask questions today. Do we have any apologies for absence?
Yes, Chair, we have apologies from Councillors Gail Smith, Dorndale and Anne Murphy.
Thank you. And are there any items for exclusion of the public or press?
Not today, Chair, no.
Thank you. I'm to ask whether any members wish to declare an interest in any of the items of business on the agenda. Nobody? Thank you. So on to item 5 on the agenda, which is the minutes of the previous meeting. Are there any matters arising from the minutes? Thank you. And if I can ask for a mover and seconder to accept the minutes as an accurate record of the meeting held on the 8th of September 2022. I have a mover, Councillor Harris, a seconder, Martin Phipps. Thank you. So those minutes are accepted as a true record. Item 6 on our agenda is public questions and petitions. Now we've had several questions from members of the public which relate to item 7 on the agenda, and we will take those questions under that item so as not to separate the discussion from that item. So we will receive now a question which doesn't relate to that. Just want to write a bit of paper. So we have a question from James Martin, representing Disability Sheffield, relating to vaccination. Welcome, James.
That one, thank you. Good morning, thank you, Chair. So this question relates to vaccination accessibility. Earlier this year, the vaccination jab cab programme enabled people where cost in particular was a barrier and they couldn't physically get to vaccination locations to be able to take a cab to one of the vaccination centres and back. I think this is vital to ensure more equal and fair access across a variety of needs. So my question is, when will the service be reintroduced? And in particular, we're keen to see this happen at the beginning of December, so that there's enough time for people to receive the jab early and then have the 14 days or so to keep on building up immunity, both for the good of the patient and also for the NHS. Thank you.
Thank you very much, Mr. Martin, and for coming in person to ask the question as well. We appreciate you attending. I think, can Jackie or Lucy comment on that?
Yes, so I am pleased to say that we are reinstating that service. We do expect it to be mobilised from tomorrow, so we're just finalising the operational arrangements, but we expect that to be in place.
I think that's what you call a result. Is there anything else you wanted to ask about that, James? Okay, thank you. Can I just ask how information about that will be disseminated? Have you got some kind of
Refer to my colleague in the corner, sorry.
I believe there will be some publication by the council, but it will also go out to council services and GP practices as well.
Okay, so we understand that it will be publicised through the council and will go through our GP practices as well to be advertised and social media.
Yeah, and through the NHS channels as well.
Anything else to add? Greg, did you?
Apologies for being like, yeah, we'll use the same mechanisms that we used last year, which were basically respin the COVID mechanisms, which I think got pretty much everywhere.
That sounds fine. Thank you. Just one last look at James. Are you happy with the responses? Thank you very much. Great, and thanks for bringing that question. So I think that's the only item that doesn't relate to item 7. So I think we will, without further ado, get on to the main meat of the meeting, which is to hear a report from NHS South Yorkshire's consultation on proposed new health centres. And we'll hear your report, and then we'll take the public questions that have been brought on that subject, and then members of the public will be very welcome to stay for the rest of the discussion, but we'll take yours first in case you need to get going. So just to give a very quick history of this item, this Scrutiny Committee this year and last year's Health Scrutiny Committee have taken reports on this item over a number of months, and we have been involved with how the consultation has been put out and scrutinising the process for that, and also examining the content of the programme and its objectives, and anything that we feel is of interest to the public in terms of how service delivery might change through this programme. So that's our remit as a committee, and today we will be looking to make recommendations following what we hear today and the discussion we have, and we may require further time after today to formulate our response. So just so members of the committee are clear, we don't have to reach a final response today. So if I can ask those who have come to present your report on this, thank you.
Thank you, and thank you for inviting us back today to present the findings of the consultation that we came to talk to you about back in June. As we previously outlined, the capital funding was awarded to South Yorkshire in March 2022 on the basis of proposals worked up by practices within South Yorkshire. The funding has strict conditions attached to it, and to be successful in drawing down this funding, we do need to meet those criteria. So what we just want to do quickly, because I know there's quite a lot of information contained in the paper, so and there will be quite a lot of questions, so I don't want to take up much time with presentation, but I will ask Lucy just to outline the consultation process and the findings, and I will just cover next steps, and then we will open to questions if that's okay. So Lucy, do you want to go through the consultation?
Thank you. So today we've got a report in front of you, so hopefully you'll feel that it's very detailed findings and you've had a chance to read it. So NHS South Yorkshire consulted the public in the northeast of Sheffield on the proposal to move 9 GP practices into one of 4 new health centres. So we're here to you today as your view as a consultee on the consultation, on the proposals. And obviously you've got the views of the public to help inform your decision. So we heard from 5,000 people, a really robust sample, and we carried out a multi-method approach, so surveys, some of those were face-to-face, some of them were online, some of them were paper. We held 16 meetings, we took feedback via emails, via social media, and we funded 17 voluntary community sector organisations to reach people that we knew perhaps wouldn't respond online or paper, or they wouldn't answer the phone, wouldn't have, maybe even have a phone if telephone market research company contacted them, and also to help raise awareness. And they also carried out surveys in different community languages as well. So really good representation. So it covers at least 1,000 people in each one of the 4 hubs. Good age range, good range of ethnic groups. It's represented by disability and by gender as well. So I'll just take you through just 1 or 2 findings for each of the health centres. So for Foundry 1, over half thought the proposals would have a positive impact on them, but travel was an issue, and it was with most of the health centres. But 73% of people told us they would continue to stay at the practice if it did move to a Foundry 1 health centre. So for Foundry 2, this actually was the most popular proposal. So 3/4 of people told us it would have a positive impact on them if it went ahead, and 80% would continue to stay at their practice if it moved. For SAPA 1, this actually was the least popular, so those people were least likely to say it would have a positive impact on them. It's actually less than half of the people we surveyed, but 2/3 of people would actually told us they would stay with the practice if it moved. And for SAPA 2, over half of people said it would have a positive impact on them, and vast majority, 80%, would continue to use the practice if it moved. The issues that we heard were around travel, and lots of people were very empathetic, and they were worried about the impact it would have on older people, disabled people and vulnerable people. But looking at the answers from people with protected characteristics and those that were disabled and older people, they actually were slightly more likely to say that they would be impacted. And so we've got also, in parallel to this, we've got equality impact assessments, and all that information will be used to inform the final business case. So I'll just leave it at the high-level summary of the results, and I think Jackie will go through next steps in terms of decision-making.
Yeah. So whilst we undertook a single consultation, the next steps will be to produce a decision-making business case, and that will come back to this committee on the 7th of December. I should point out that the funding was initially allocated to the programme based on a bid that was produced in 2018. Members will be aware that since then there have been a number of challenges that put pressure on programmes like this, most notably building cost inflation and workforce pressures, which means that initially when we put forward the bid, there was an expectation of economies of scale of developing projects simultaneously. The feedback from the building industry is that that is no longer realistic, so we will need to take these projects individually. So we are managing a number of pressures in terms of the overall programme. The consultation findings, including this committee's response, the quality impact assessments, as Lucy has referred to, an understanding of individual practices' commitment, and an assessment of deliverability, affordability, and the impact on individual hub proposals will be used to inform that decision-making business case. The draft decision-making business case will be presented to the initial meeting of the new Sheffield Health and Care Partnership Board. Apologies, I made an error in the paper. I said that was the 1st of December. That will meet on the 6th of December. And the Health Scrutiny subcommittee will receive that draft decision-making business case on the 7th of December. Having had comments from that, a final business case will be presented to NHS South Yorkshire's board on Wednesday the 4th of January for a decision on which, if any of the health centres go ahead. So we would welcome comments and questions on the overall findings, but I would also want to understand the committee's views on the individual hub proposals, not just the programme as a whole. So I think that's all I wanted to say to introduce the item, so I'm happy to take questions.
Thank you very much indeed. I think we'll go straight to our public questions, so we can hear those first and give the folk who have come along a chance to get going if they need to. So if I can ask James Martin to come back to your microphone and give us your questions about this project. Thank you.
Thank you. So, first of all, we were involved in helping to gain informed feedback from individuals, and we're glad to have had the opportunity to do that. During the consultation events run in conjunction with other partners, some key mitigations were raised in multiple settings to ensure that proposals would be adopted are accessible to all. It is vital that engagement and consultation continues and is done early in the implementation of any of the schemes that go ahead. Therefore, will the committee and NHS identify actions to ensure that pan-disability engagement working groups are established for both of the following? Firstly, building physical design accessibility working group to ensure that the various things that make a building more accessible for people, whether since having a sensory impairment or a mobility impairment or other conditions, will find the building as easy as possible to access, both in getting in and then getting around the facility. And the second working group, looking at the operation of the building. Several different groups with sensory impairments in particular identified concerns and issues with being able to find their way to the right place where there's going to be multiple GP surgeries operating from the venue, and no doubt there will be other challenges. I think all of this is really vital to engage with, so that people of Sheffield find this as positive as possible if they're affected. And if I may, Chair, as Joanne Arden isn't able to come, I might quickly summarise a couple of the points there.
Please do, yes.
Yeah. With this in part relates to the operation of the building, but goes a bit further. It seems that with combining multiple staff teams into the same site, that actually the opportunity to boost skills and confidence, looking at both those who have hearing impairments, providing deaf awareness training to the staff team, and also visual impairment awareness training, would all be really helpful and perhaps more affordable than individual surgeries trying to do that at this time. So yes, be grateful if that's considered as well. Thank you.
Thank you very much. I'd like to just respond to say that I think these are all really vital things that have been brought up, and I mean certainly not considerations that I'd necessarily thought of. It's absolutely key that disability groups are able to come in and give such comprehensive advice really about how to go forward. So I really want to thank you for bringing that and for all the work that you must have done to collate those views and put them forward in that coherent way. And we will, as a committee, we will certainly ensure that all of that is built into our recommendations. Is there anyone who'd like to respond straight back to those?
I'll do that, thanks, Councillor. Yeah, thanks for your questions, James, and thanks for your help with the consultation. We agree with everything you've suggested, and you'll be pleased to know that we've always our engagement plan right from the start included 3 phases. So the first phase was the pre-consultation engagement, which helped inform the proposals that we consulted on. So the consultation was the second phase, and the third phase is involving people in the design of those buildings to ensure that they are accessible and actually they become really vital community assets. The buildings will be built to the highest accessibility standards. They'll be dementia friendly, they'll have lifts, a lot of them aren't accessible at the minute. We will involve people with lived experience, pan-disability groups, and we'll work with you and with Kate in ensuring that, we really do have great representation in the third phase of the engagement, if that sounds okay. And just on the wider point of training practices on accessibility and helping people who are deaf or visual impairment, NHS South Yorkshire has a plan to carry out that training with all practices. So we'll be starting in, a small number of practices on accessible information standard and a lot more, because we know that actually there are practices that are letting these vulnerable people down. So we do have a plan for a programme of training and general awareness and support.
Great, thank you. That's really good to hear, particularly about the last bit that you mentioned there.
Thank you. And I think that addresses some of the things in the consultation findings, doesn't it? A lot of the comments that were brought forward from consulting with disability groups. So it looks as though you've built all that in already. Can I just ask, how early on in the building planning stage will that kind of co-design work be able to happen?
Well, I think as soon as the decision has been made in January, so we want then phase 3 to start in January. I don't know if Jackie might go into this, or it might be next time, but the construction has been put back a bit just because of the issues that Jackie spoke about, you know, around affordability and pressures in the building industry. So actually we've got a lot more time to do that than we ever thought. So the plan is that we'll start sort of January, February, so, you know, very soon.
Okay, thank you very much.
One more point, if I may, that I've just remembered. This is particularly relevant to the council as well as the NHS. In terms of visually impaired people, in particular navigating to new sites, they will often use the mobility training service, which is provided by the City Council, but that is still struggling with a significant backlog. And, you know, access to healthcare can't afford a long, you know, potentially year-long wait. So I think there's going to be some careful thought required and maybe some cooperation to identify the best solution in that area.
Yeah, totally agree. Greg, do you have anything on that?
Yes, in short. I don't know the answer to the backlog, but yes, in principle is would be my answer to the question. It's not okay that people have to wait a year to get support to get a GP appointment.
And we're aware of the long waiting list as the council service, so we're building that into our mitigation as well to make sure that we do something, you know, well ahead of the centres opening if they go ahead.
Well, I mean, is there a concrete plan that will actually result in greater capacity for that service to bring training in? Because we can't really be in a situation where a lot of people are having to change where they access healthcare and having to join the end of a long queue.
I don't think we don't have any concrete plans yet, but we are working on it, and we need to work with the council, and yeah, because it is unacceptable.
Yeah. Do any members have any other comments or questions about these particular issues brought forward by the disability groups? Nothing particular. Okay, thank you. Thanks very much again, Mr. Martin. So we've covered the question that was brought from Joanne Arden from Sheffield Royal Society for the Blind. I think we've covered that one. So we have questions from Jeremy Short, representing Sheffield Save Our NHS. If you'd like to come up to the microphone, Jeremy, thank you. And thanks for coming today. I think I'll leave it up to you if you want to divide your questions up and ask for a response to each one, or if you'd like to give them as a batch. I'll leave that up to you.
They're fairly short, Chair, so should I just read them out? These are on behalf of Sheffield Save Our NHS. We have raised questions on the GP hubs before, and some of our members did attend some of the consultation meetings through the summer. We've got 6 questions, and they're all focused on the actual report before the committee. So firstly, in the background, it stated that we hope building new health centres will attract more clinical staff, as doctors and nurses want to work in modern, more spacious buildings. So our question is, given the national shortage of staff, is there a danger that the project will merely attract staff from practices based in older premises in Sheffield, therefore creating staffing problems for these? And has the ICB given any thought to this? The second thing is, will the provision of modern buildings anyway itself be enough to attract GPs to work in deprived areas? And then thirdly, will the change to salaried employment for existing GPs, instead of having investment in current buildings, make it more likely for GPs to move out of poorer areas? So again, exacerbating a staffing problem. In the next steps, reference is made to building cost inflation. With the continuing increase in inflation rate, will this leave the council exposed to cover any shortfalls, or is it guaranteed to be covered by the NHS? And then on the consultation process itself, I think you refer to the fact that SAPA 1 is the least popular project at the Concord Sports Centre, but can it be justified given the doubling of average travel time and the fact that 44% saw no advantages in the proposal against 28% who saw no disadvantages? And finally, connected with that, what steps are planned to maintain or even improve accessibility for vulnerable patients?
So if I just take each of those questions and point to who's going to respond to them, I should say we have prepared a written response as well, so that might go into a bit more detail, so we will make that available, but we'll cover off each of those points if we don't mind. So just in terms of the first question, I think we recognise there are severe pressures in terms of general practice and practice staff at the moment. We recognise that this is not kind of a really simple problem to solve. But what I would say is that practices working in deprived areas aren't operating on a level playing field. They do find it harder to attract staff, and some of what we are trying to do here tries to address that. But if I pass you over to Dr. Meek, he'll explain some of the pressures that him and his colleagues face on a day-to-day basis and how this might address some of those.
Yeah, thanks for the question. I think they're all very good and complex points, would be the first thing I'd say. So I'll go through the first three myself, I think, primarily. And I think the first two questions you can sort of answer together, that the biggest challenge, I think, at work, so I'm a GP at Firth Park Surgery, as my sort of main job as such, is getting GP trainees into the area is a big one. We actually are lucky at Firth Park that we have a good sort of GP training programme ourselves, just because our building happens to have enough rooms, but most of my colleagues across the rest of the network don't really have the facility to house trainees. They just have rooms for them to consult out of, and building these hubs will allow them to do that. And to give a concrete example at Firth Park, I would never work there if I hadn't trained there, but now I really enjoy it. And all my colleagues at the surgery trained there, every single one of us, and probably the only surgery in the network that is fully employed on where it wants in GPs. So GP training is by far the best recruitment scheme for GP practices, and therefore if you build bigger buildings that allow the other practices to become training practices, it will allow them to recruit more GPs. It's proven time and time again to be the easiest way. And then you've got the kind of new roles that are coming more into GP, so things along physios, pharmacists, mental health workers. They're kind of new roles in primary care. I employ them across the network in my other job as the clinical director for Foundry. And we have massive, I think estates is probably our biggest issue for recruitment and retention of those staff. Our mental health teams currently have to work from home. So I have 3 mental health workers I employ across the network. And they have to review patients from home rather than being able to see them face to face at the surgery, which is clearly what everyone wants, simply because there isn't rooms for them to see the patients in. And last year we had 2 of those members of staff mental health practitioners leave because they were dissatisfied with having to work in that way. So I agree there's staffing shortages in general in the NHS, and that's not going to fix this. But I think working in the areas we do give quite significant retention issues, and this will definitely help retain staff. It's not always about getting them there in the first place, it's about keeping them there. And I think this will do a long way to solve that. I think that hopefully answers 1 and 2. Around point 3, it might be helpful if I just briefly explain how a partnership works and the difference between a salaried and partner, because I agree with the premise of the question. If it was forcing us all to become salaried GPs, it would definitely affect us wanting to work in the area, shall we say, but that's not what the scheme's doing really. You can be a partner where you're self-employed, you run the business, and your income is essentially a profit share of the business, and part of your job is seeing patients, and part of your job is running the surgery. And you can do that in a way where you own the property, or a way where you don't own the property. Historically, owning the property was actually often quite a good return on investment, and people wanted to be property-owning partners. In the same vein as most investments nowadays, that's not the case really, and it's becoming quite a difficult thing that people don't really want to do anymore. So what this scheme would do is allow the partners out of massive loans hanging over their heads essentially, and into a model where they work in a building lease from the council. So they're still a partner, they still have all the benefits of being a partner, but they don't have the kind of loans hanging over their head from being a property owning partner essentially. So if it was forcing the GPs to become salaried GPs in the area, I agree it would disincentivise people to work there. What it's actually doing is providing a route to a better way of being a partner, in my opinion at least, which would therefore improve recruitment and retention in the area, hopefully.
So in terms of question 4, simple answer is no. So the building cost inflation is an issue, but the point at which the council would take on the responsibility, we would have let contracts understood the tender costs, and the funding would transfer in line with those tendered costs. So the council doesn't take on the liability, subject to them agreeing to be a delivery partner. They wouldn't take on the liability until the point at which those tender costs were known. In terms of question 5, as we've recognised, the SAPA 1 consultation did identify that travel was an issue. Interestingly, it was the 4th most important point ranked by the respondees in terms of importance, walking distance, and actually was lower compared to some of the responses for the other hubs. But we do recognise that you know, both on the calculation that we did as part of the consultation and the self-reported distance, there was an increase. There was a difference between what we reported based on where people live and the average for the respondees. But that is one of the issues that clearly we will need to take into account in informing the decision-making business case. And then finally, the steps to maintain or improve accessibility. So we've talked about some of the proposed design adjustments that we will do. There is also just more generally about how to improve access for patients, and in the consultation we talk a lot about bringing other services closer to people, so that improves accessibility, and attracting and retaining staff hopefully will allow us to stabilise and hopefully improve access times. Josh, is there anything else you want to add to that question?
Yeah, I think it depends, I guess, how we classify vulnerable patients, but I think a lot of my patients, you could probably say that in one way or other, and there's definitely a disparity for our patients in a lot of services happen to be at the Hallamshire, essentially the other side of town, and most of my patients don't own cars and can't afford a taxi, so literally won't go for over COVID, for example, they stopped doing chest x-rays at the Northern General and would only do them at the Hallamshire, and most of my patients therefore didn't go for chest x-rays because they couldn't afford to get there. That's genuinely true. Whereas if you provide and what I'm not saying obviously is none of these hubs are built with the capacity to immediately x-ray people, for example, but if you build a building to modern healthcare standards with enough rooms and enough sized rooms to do that kind of thing, it allows you the ability to try and get those things more locally. So whilst they won't immediately have those kind of services, they are at least buildings that could in theory do them, whereas the buildings we're in at the minute, it'd just be impossible to do anything. So there's loads of stuff where our patients can't afford to get to the centralised site it's done at, where we're hoping if we can bring those sites more local, they would be able to.
Thank you. Is there anything you wanted to ask further on that, Jeremy?
No, I think what we do, if it's okay, we can wait for you're going to send us a written response. So if you can have a look at that, and then respond back to you if you want to raise any more points, if that's okay.
That's fine, yeah. Okay. Thank you very much for coming in. Thank you. So, if members want to raise any questions further to the public questions that have been brought, I think that would be a sensible way to guide our conversation if there's anything arising out of those that you want to follow up on. Councillor Oxley, yeah.
Chair, thank you. Just following up on the waiting list for the mobility orientation that James mentioned, and is that waiting list sat within a council service, and what can we do in terms of to investigate why there is that waiting list, and what can we as a council do about that? Because obviously, as Greg said, it's not good that people are waiting for a year's appointment just because we're not delivering that service to them.
Yeah, I think, as I said, we don't want to be stuck in a place where we acknowledge the problem but can't do anything about it. So I guess the question is, who's the accountable committee or person? Is it you, Greg?
It's probably not me, and I don't know the answer to the question, Councillor Oxley, but I'll commit to go and find out the answer to the question and work out what we can and what we can't do within the powers and resources that we've got. But the short answer is I don't know whom it rests with, officer or councillor-wise.
Thank you. And is it possible that extra funding for that service might be levered from elsewhere if the council is struggling to fund anything better?
Again, I don't know. We all know the position the council's in, financially speaking. So if there is extra funding in this, it means less funding in something else. That is an inherently political decision. And off the cuff, I can't give you an honest answer because I don't know the facts.
Thanks. Yeah, Mr. Martin, yeah.
Just in terms of the backlog, I mean, there was always a wait, even pre-COVID, but the reality of how you provide mobility training for people is, you know, relatively close contact because, you know, you'll be guiding with the elbow and that sort of thing. So that paused for a very long time in the pandemic. So that's why it's, so dramatic. It's not necessarily an easy problem to solve, but I think we really need to weigh up the big negative impacts if we ignore it. Yeah. Thank you.
That sounds to me like we're talking about clearing a backlog with a single injection of resources rather than needing to step up the service very long term. So if Greg's happy to take that one up fairly swiftly, that would be great. I'm sure we've got a lot of questions about other parts of the consultation, so we'll open it up to other topics as well. Councillor Mohammed.
Thank you, Chair. Thank you for producing a very detailed report. I have already raised concerns via email. It's probably important for me to raise them again today. So I've got very serious concerns with how the research was conducted and the ethics of the consultation. Initially, when this came to one of the earlier meetings, we were given the opportunity to be involved in being readers for the potential questions. That never materialised. So when the full consultation was being conducted, it was still based on very similar leading questions that were initially in the pre-consultation. So when sort of a particular incident happened, it kind of reaffirmed not a position, but just a very serious concerns about how this research was going, almost in a direction where it felt as though we were making the research fit the answer, the solution that we wanted, rather than being open and objective to genuinely hear from the public. So I'll explain the situation that happened. I was with a member of the public on a particular Saturday morning doing a litter pick, and we were approached by two of the researchers who were from this company that have consulted with over 4,000 people, and they had a pen and paper and asked us very vague questions, didn't make any notes, and when we questioned them on, well, when I questioned on how that was going to be recorded, they came back and said, well, at some point, either tonight or tomorrow, we'll record the findings on the laptop and fit sort of the specific questions that were on the questionnaire that they were going to fill in. So we probed on this because, you know, obviously there were separate questions that were going to be coming out through the online questionnaires that people could answer, but they didn't note anything down. And so when I asked the two ladies, you know, how they were doing this, and it was purely coincidental that it ended up with me, sort of that they'd come to speak to. They said, well, this is how they've done it across all four areas, and they'd worked through Burngreave, in Page Hall, and in Firth Park. And they'd gone into the park as well, and I questioned when they were talking to a couple of Pakistani ladies how they were making sure that these women understood them, and the response was, we get the gist of what they're saying to us. For me, that is really unethical, that if somebody has language barriers, that there must be translators there. So I think from the start, we've always asked for this research to be done and the consultation to be done as ethically as possible, as objective as possible. Where questions were leading initially, we asked for us and various other members of the public to be involved in making sure that they were not leading and objective. And I think going forward, the reassurance that I want is from these 4,000 individuals that were part of that SMSR consultation, how can we ensure that those responses are valid and objective and people weren't just, I don't know how else to say this, but fudging the research just to make sure that we get the response that we want to conduct these buildings, because it just feels like we're going ahead regardless. And then, so that's on the research side of things. The other point that comes up and that sort of comes out from the research is all about access to appointments, and that was the ongoing response that I had from members of the public. So whenever I attended some of these meetings, and I think there are questions on the numbers of people that actually attended those meetings. I don't think they're correct from what's in the research, because we had feedback in terms of how many people attended some of those meetings, and some of them are not accurate. Some of them are lower and some of them are higher. But the main concern that the general public had was, we want to see our GP quicker. And there was no sort of information that was given about how moving to these centres actually wasn't going to solve that problem. And when we've had previous meetings in Scrutiny, we've probed on that particular question. We've probed on the question of, you know, is moving to these new buildings going to increase recruitment when we know it's a national shortage of GPs? And in the past, the response has been, it's not about that. It's about getting, you know, better buildings, better services, and making sure we can increase the partnership work in the buildings. And so so that the question still remains there, that the general public are asking for better, more efficient appointments with their GP, but this doesn't actually solve that problem. And then the final point is in relation to buildings, community buildings, and what will happen to empty buildings in areas of deprivation where already we have empty shop fronts and nobody really gives any care to what local areas look like, other than the people that live in those areas who are genuinely concerned about having empty derelict buildings in their areas that don't look very nice. On one of the occasions, I went with a couple of GPs to look at one of the facilities, potential facilities, and one building, the Sheffield Medical Centre, has no plans to be part of the bigger plan. And the idea was, and this came from the GPs who I think own the building or would have a recommendation on what happens to that building, was that would be changed into a community centre. My response to them was, well, we've got several community centres that are struggling to stay open and are struggling to stay sustainable. So how can people who don't live in the area make decisions on what they believe to be viable or unviable? And, you know, the people that will be left with an eyesore are people who, as I've said earlier, live in that area. So to what extent can we tie, and if this goes ahead, how can we ensure that these buildings tie into what's needed in the area, rather than owners or leaseholders deciding what they think is viable, or selling it off to a land banker and they stay derelict for 10, 20 years, and the people that live in those areas have to deal with those eyesores. So there's a number of concerns there, but I think the main one is really in terms of the ethics of the research. Thank you.
Well, thanks for your questions, Councillor. So I'll pick up the ethics. We did actually have a readers panel for the survey, and I'm really sorry if you didn't get the invite. I thought Scrutiny did, so that's an error on our part, so I'm really sorry for that. But I know practices were involved, some community groups were involved, I think maybe Health Watch were involved. So they looked at the communication materials and the questionnaire. So because we really listened last time when you said from the pre-consultation engagement that questions were leading. And actually I don't think the questions were leading this time. And taking about the concerns about the research organisation, so when you shared those, we're really concerned as well. So we've looked into it with the company, done a bit of research. The company, so they are very experienced. They work all around the country. They meet the highest quality standards, and their field researchers do as well. They don't go. So your experience, some of the things that aren't in line with what they're supposed to do. So they don't go around with pen and paper. They go around with tablets. So they ask the questions and then record them straight away. And their quality processes are that they take the telephone numbers of everybody they interview, and they have quality checked with 10% of the sample, which is 400 people, and there wasn't any complaint or concern. Not saying that obviously it didn't happen in first part, but from that we've looked into it, and it's gone to our sort of engagement committee, and we are assured with the quality of the consultation that they took on our behalf. There probably will be some, they're freelance workers, and they might, there might be the occasional one that perhaps didn't follow that true process, but that's why we built in that really large sample size. So I think of the 4,000, we are assured by the findings we've got back from the streets and the telephone research. About the translations, so I totally get your point. I don't think that is appropriate if they if their understanding of English isn't very high, but we knew that the on-street interviewers with face-to-face researchers from Sheffield and Hull wouldn't get to people whose first language wasn't English, and that's why we commissioned a 17 community voluntary sector organisations. So one of the main partners we worked with was Vale Community Hub. They did a lot of the interviews in community languages on our behalf, and we actually translated some for them, so they could just go through it. So we think that's how we got up the numbers of people from an ethnic minority background. So it wasn't the SMSR bit. So when I explained at the beginning, it was multi-method. We know that on-street interviews are not going to reach people that perhaps don't speak English, and so that's why we had lots of different methods. About your question, and I think your query that actually we asked the questions to get the information that we wanted back. Yeah, we did, and actually the views from the different health centres, they vary, and actually, like in your ward, so SAPA 1, actually the majority of people don't think it's positive. So I disagree when you say that actually we got the answers we wanted, because we wanted to hear people's genuine views, and we have heard that. Actually, it hasn't landed that well with some populations, and I think the survey reflects that. And I think we haven't got 80-90% support across the board. So I think it is objective, and I think we have got the results we want to inform our decision making, to make sure that the services that go ahead do meet the needs of all our populations. And I think we've got that. And the report has actually gone to our engagement and equality committee, who are reassured by the consultation we carried out. And they'll be assuring our board on our behalf. And what was other about the meetings as well? I'd like to know sort of which of the meetings that you think we've got the numbers wrong, because we actually have double checked them. Because in the first draft there were a couple that were low, but even if the numbers are low, we recorded what people said, and that's gone into and informed the qualitative analysis. So that is in this report. So even if there is a typo, then actually what people have said in the meetings has been recorded. But yeah, if you could let me know which numbers you think are a bit low or a little bit high. Because yeah, we checked and triple checked. But I think that does that answer most of your questions about the consultation? I know you asked something about, you know, GP, where it's all the GP problems and empty buildings.
Just in terms of access to appointments with GPs, as I said at the beginning, we know this is a really complex problem that buildings in isolation will not solve. But we have had a unique opportunity, and to be fair, it is unprecedented in terms of having the offer of investment in this part of our city that's not had the investment in the past. So we see this as part of the solution, but it will not address access to general practice in isolation. And the item that we're going to take after this, we can talk a bit more about that. But as Dr. Meek has outlined, there are a number of opportunities that start to address some of the issues. So I don't know, Josh, whether you want to answer a bit more in detail.
Hiya, thanks. Obviously, GP accessibility is a big issue at the minute in the news. It's not great for, I think, variety of complex reasons, and knowing a building doesn't instantly fix that, or any build, nothing instantly fixes it. I think there's a few things in this scheme that will help, in all honesty, particularly around the partnership and ownership model. There's two current models where you can own your building, really, or lease off your building. You can be a partner and you own it yourself, and you generally have a mortgage on it, basically, and the investment you get back now doesn't really often cover the mortgage payments. Or you can, therefore, what a lot of people do is sell it to a big private hedge fund company and lease it back off them, and they basically rinse profit off the NHS. In short, what this model does is it's kind of like you're leasing it, so you don't have the risk yourself, but you're leasing it off the council, so you're kind of leasing it off a partner group who's going to be more favourable to each other, obviously. I would suggest this will become the most... I think if you ask most GP partners if they could be given this option, they'd say yes nowadays, and I think it will therefore make quite a attractive, competitive partnership opportunity in that kind of area of the city. There are, at the top of my head, I can think of 3 practices in our network that are currently struggling to recruit partners entirely based on the ownership model of their property. And these are practices going into this scheme. It would immediately solve the ownership issues they're having, and therefore hopefully help them recruit new GPs, because the reason they can't is because of the ownership model of their property. So no, it doesn't instantly fix it, but I suspect it will make it easier to get partners into the area. And going back to my previous point, it will definitely make it easier to get more GP training done in the area, both of which will in the longer term increase accessibility, hopefully.
Greg, was there anything you wanted to add?
Yeah, just to add, so from my speaking to GPs in that part of town and other parts of town, I concur entirely with Josh's view on that one. On Councillor Mohammed, your point on the empty buildings that are left, it's a good point, and probably depends on who the owner of those buildings is, and it might be something that the committee wants to build into its recommendations. I don't think we've reached a final, well, the ICB's reached a final determination on how that aspect of the buildings being left plays out, but I agree with you, no one wants long-term voids.
I would just add that as a process has been really valuable for us to actually understand more about the health needs in the area. So Lucy's team have been doing a lot of work around with our community groups just to look at that, because I think you're right, some of the assumptions that we made when we started with the pre-consultation work was that we could do X or Y, but we've learned a lot more about, you know, the infrastructure, the community infrastructure in these areas, and we've made a commitment to work with those groups to actually understand what the communities want, not what we think they need. So I think the whole process has been quite a good education for us in terms of that. Practices obviously are working really closely with their communities, but there are still areas where making more connections with community groups will stand us in good stead to addressing the real needs, the health and well-being of those populations.
We've got Councillor Lee and then Councillor Phipps afterwards.
Yeah, my question really just honed down a little bit on the research, and I'm just looking through the numbers of older people, and I'm talking about people over 65 that might have responded, and it's much less in terms of percentages than the rest of the respondents. And I just wondered if you've reached enough older people that you particularly need to understand what their needs are. So the percentages of the respondents, how does that compare to the percentages of older people on GP lists? So that's one question. And just in terms of the responses people made, you know, as a younger people, less frequent users of health services, think less about using health services. It's not on top of their list of priorities. So we'll think, yeah, new building, that's absolutely great there, let's go ahead with it. Whereas older people, more preoccupied, think more about their health, have to think more about their health, getting from A to B, doing all the things that are related to health, to their health, whether it's hospital visits, GP visits, medication, pharmacies, all those sort of things, will have more concerns about any changes. So I just wondered, have you done enough in-depth work with older people and more vulnerable people as well, the disabled, that you need to do? Because, as I said, younger people will, quite right, they don't think about health services as much, and we wouldn't want necessarily, we don't want them to be more preoccupied with health services, but you know, you get the gist about that one. So just, is there enough done? Because it seems to me they're the problematic group in accessing these new services if they go ahead.
Thanks for your question, Councillor. Yeah, it's a good challenge. I think if you take the overall sample size, we have got enough people from, you know, the over 65, so over 5,000. I think it's about, you know, over about 20% from that group. So actually, we can do the, you know, sort of analysis at the sort of age level and get really deep into it. So your point about actually older people are more likely to use health services. So we did go from it, actually, we didn't look at it actually the patients and who uses services, but we also looked at it from a population level, so who might be a future user. So overall, I think we've got a big enough and a rich enough sample from older people, and we also commission voluntary community sector organisations, and I know they actually had a lot of conversations with older people and look about people with disabilities. We did work with Disability Sheffield, so James did great work with us, and also Deaf Advice Sheffield and a few other organisations to get those people that perhaps, you know, would be disproportionately affected if the changes went ahead. But I think, you know, from a sample of about 5,000, we've got, you know, 800, 900 people who are like over 65. And it's broadly reflective of the population of the North East Sheffield. So if you break it down at a practice level, it wouldn't be, but at the kind of North East Sheffield level, the responses we got back do reflect the broader population, not practice lists, but the people that live in that area.
And just on that then, the people who carried out the surveys and the consultations, the community groups that did that with you, I'm assuming those, that the way they made contact with older people was when older people visited their services or their buildings, and that's how they or did they go and visit people in their homes? Did they do the service that way?
So it piggybacked a lot on existing work. So, for example, you know, like social prescribing, so SOAR were heavily involved, so it piggybacked on the social prescribing work. You know, if people went into Prevail Community Hub, they'd have conversations. You know, they often, some of the community groups we work with, say give food parcels, so when they're delivering those, they'll have a conversation with somebody to raise awareness. If you've got any concerns, you know, do you want to share your views? We worked with the TARAs, so the Tenants Association. You know, obviously, you know, a lot of older people live in sort of, you know, social housing, so lots of different ways. We weren't prescriptive, so when we gave the grants to voluntary community organisations, we thought, you know your populations, you know the most effective methods to reach people, and it was hugely varied, so whatever worked for them and their populations. And I think if some of the organisations set up telephone helplines, especially for this as well, which we know, you know, sort of telephone, landline number is going to be more comfortable more familiar for people from an older background than it might be younger people. So.
It's probably worth adding as well, the equality impact assessments will look at the protected characteristics of the respondents and our assessment about mitigations for those specific groups. So it won't just take the general population, it will take into account age profiles and disability.
Thank you. And the people that came to the meetings, actually, they were more likely to be from the older demographic than younger people. So.
I've actually got a follow-up question on that, if you don't mind, if I just follow that up first, Martin, thank you. It's just really that numbers on paper are one thing when, you know, you write a report from the consultation and analyse the findings and things get produced on paper, but just to sort of really go to the other end of things away from a piece of paper on a desk and look at the real lived experience of some patients that we're talking about here. And as Councillor Lee was driving at, you know, for older and more vulnerable patients, you know, is there a real risk here of cutting them off from timely health care? And where do you draw a red line? Where are you going to draw a line and say, actually, we're creating a situation where for patients it might be getting worse, whereas from, as Josh has indicated, from the actual sustainability of general practice, things might be getting better. And how do we marry those two together? And where is that dividing point where you say, actually, the balance is in the wrong direction? And really, it's, you know, how do you get to the heart of what the lived experience is for people? And particularly as we've lost bus routes, and there are factors like that as well that are very unstable in the current climate. And we've got drivers behind all of these considerations, as well as a council, such as our commitment to building 15-minute neighbourhoods. Are we here, looking at something that actually goes against that commitment? And there's the NHS commitment, and it's throughout all the documentation with the new integrated care system, which is great to see. A real commitment to sort of getting the NHS away from more acute care to more preventative, community-based, keeping people well for longer, keeping people out of hospital for longer, that sort of side of things. So if it does come down to that for a patient, this change makes their physical access to a healthcare appointment incredibly difficult, is that meeting that objective of keeping them well for longer in their community? So I don't know where you draw your line.
Yeah, and there is, it is quite a subjective position we get to at this point, isn't it, in terms of being able to take a lot of information. So I think myself and Lucy have obviously done quite a lot of trying to understand what the data is saying. I think maybe if I'd pass over to Josh, because Josh has had individual conversations with patients, and obviously as a practice, this is at the heart of what they're grappling with.
Yeah, so I've got 2 points to answer. I hope will be helpful at least. Obviously, a lot of my patients, these are obviously incredibly sort of anecdotal, but as you say, that's important as well. And a lot of my patients that I see regularly, older patients, very vulnerable patients, that kind of come and see me as their regular GP. I think we're fair to say it's probably not a shock we're initially against the idea. And then sat and spoke, and the biggest question they asked us actually is, their concerns have always been, are you going to be doing a merger? I'm not going to be able to see you anymore, because continuity of care is very evidence-based, so important, and also people prefer it. Their biggest questions are always, am I going to still be able to come and see you? Is the surgery still going to operate like it does now? You're not going to merge, etc. And once I answered those questions in that, yes, it's just going to be exactly like it is, but teleported up the hill, essentially. They didn't really care one way or the other, was the short answer. I think in terms of, and you're right, there's definitely 2 sides to this: sustainability of general practice and good care for patients. And I don't know where the line is, that's not for me to decide, but it's clearly an important line. And for example, as Lucy said earlier, one of the hubs hasn't gotten particularly good feedback on the location. That obviously I presume gets taken into account. The short, slightly odd answer, which I suspect some of my colleagues would hate me for saying, is we have a contract to provide appropriate care for anyone on our list who is within our practice boundary. So in terms of accessibility to healthcare, at our current building, we have patients, we do home visits for rather than coming to see us, simply because of the poor accessibility to our building. So our ramp isn't very good and we don't have a lift, in short, and we have patients that can't access the building, and we do home visits. There in the new hub, those things would obviously be much more accessible. There'd be lifts, there'd be bigger corridors, there wouldn't be as many narrow, windy staircases, etc. So the building would be naturally more accessible. But some people, for disability reasons, won't be able to physically get there, possibly. And I suspect that the patients who are getting home visits from us rather than coming to us would shift towards those groups. We have, as I say, a contract to care for them, inclusive of their disabilities, and therefore, if that means us visiting us home, it's not ideal from our perspective, because it's a lot more time consuming, shall we say, but they still get the review they need. And I just suspect what would end up in practice happening is patients that currently get visits because of the lack of access to the practice will now be able to access the practice, and there'll be certain other patients that could no longer would then end up getting home visits, because we still have to look after them one way or the other.
Just to add, I'm a big fan of the 15-minute neighbourhood concept, and I think that one of the things the committee may end up considering is kind of how you recommend building in an ongoing and open and transparent consideration of the various trade-offs in that process. I think that would be really, really good, and it would be a backward move to kind of set up something that doesn't allow us to live with the principles of the 15-minute neighbourhoods. Just to build on Josh's point on the sort of the access, sustainability, the access to practice and then sustainability of practice trade-off. Practices, as they become less and less sustainable, which we'll hear about in the next agenda item, inherently that reduces access. So we need to make sure that whatever we end up doing maximises the sustainability of the practices per se, because again, we don't want to erode that by an act of omission or commission.
Thank you. Councillor Phipps, your questions.
Thank you, Chair. Greg's jumped ahead of me. I was just about to start talking about 15-minute neighbourhoods, and you've beat me to it. Just following on from Councillor Milsom's question about how we balance different needs and different responses, I was just thinking about the feedback from Harry's surgery patient users in Foundry 1. It was a relatively small amount of people that responded to the survey, I think just over 50. So there's maybe some issues there about maybe a low sample size for that particular practice. But in general, they felt like the proposals weren't for them, like quite high negative feedback from that particular practice. And I guess I wonder how we balance feedback from patients from that in particular practice against the overall proposal for Foundry 1. But I guess the same principle could be applied for each of them, because we could be significantly disadvantaging users of one practice from the proposal. So how do we kind of balance that? So that's one of my questions. I've got a few if that's okay. For SAPA 1, so 33% of the respondents felt the proposals were positive, 34% felt they were negative. So I know we've touched upon that is the practice with the most negative feedback. 42% of over 65s said the proposals were negative, and they were the groups that most frequently used the practices. I know it was mentioned that 2/3 have said that they would continue to use the new proposed practice or co-location, but I don't think that should be taken as a positive indication necessarily, as you could think that the proposal will make the service worse for you, but still say, well, it's better than having no practice to go to. But that's not necessarily a positive indication. And again, on SAPA 1, thinking about our agreed ambition for 15-minute neighbourhoods, looking at the time to travel to that practice out of the proposals, that looks like the one in particular that's not fulfilling that. So I think there's issues around that. Thinking about the points James raised earlier, are there ideas, plans already kind of in place or being thought of around how the ICB and the hubs could put in place support for those who are disadvantaged by the move and no longer find their GP as accessible. So in particular for older people and those with a disability. I appreciate that co-design is where we want to go with this. I just wondered if you had any initial thoughts. I think there was some mention around potentially changing bus routes, but then buses aren't in a good state as they are. I don't know if they've already been approached to see if they would have any appetite for changes, if the South Yorkshire Mayoral Combined Authority or operators have been approached. And then if it was just a change instead of an additional service, that probably would also have impacts on older people and those with disabilities who maybe are reliant on the current route. So there's another kind of issue there. Last couple of things. On the city proposal, which isn't part of this, I just wondered, will that come back to the committee if a suitable location is found? And how much time does it have left to kind of find a suitable location, conscious that we're getting towards deadlines? And just last thing, going back to the 15-minute neighbourhoods, if any of the proposals go ahead, can we ensure there's secure bike parking for staff and patients? Thank you.
Thank you, Councillor. So just in terms of taking those questions, so the Herridge Road surgery is a branch surgery of Burngreave. It doesn't open full time, so it only opens in the morning on 4 days a week and offers limited number of appointments. We know the location of that branch surgery compared to the main site is quite a distance, so we were not surprised by the feedback that we got on that. There is an issue about sustainability of that site. It is relatively close to Norwood Medical Centre that, as part of the proposals, are looking to expand as well. So there is an opportunity for those patients. I think it's 0.2 of a mile from Herridge Road surgery. So there is an opportunity for those patients to re-register. But as Josh has said, a lot of patients are keen to see that have continuity of care as well. So that is one of the things that we will be exploring with Burngreave surgery. I think just in terms of people that identified that as their surgery, so some people that use that might still have identified that Burngreave was their surgery, not Herridge Road. So because we don't split the list in terms of which site people access, and they may currently still access both sites, both at Herridge Road and Burngreave surgery, which is a relative distance to where they might live. So I think we have noted the response from that specific population. In terms of the SAPA 1 consultation, I think we have recognised that there is a level of concern that has been expressed, and obviously this committee can give us the views of what it thinks about that specific hub that will feed into the next stage of the decision making. In terms of support for disadvantaged older people or people with disabilities, clearly we need to be clear about which proposals are likely to go forward, if any, and then the firmer plans about how we involve groups and people in terms of understanding their needs will be built into the design phase, as Lucy has highlighted previously. The bus routes, surprisingly through the consultation, they were not identified as important to people as we had anticipated, but we have had conversations with the Combined Mayoral Authority. They have indicated that if there is footfall for the buses to take, and they would be really keen to understand where the new locations would be and whether they could adjust routes to take those into account, because clearly one of the challenges for buses is getting the people actually using them, so they are keen to explore whether they can work with us to do that. Just in terms of the city centre proposals, yes, we have got a potential site identified. We are going through the process of just exploring that. It is very close to the existing site, so we're not expecting that there will be a significant change in terms of access for people, but yes, we would bring back to this committee any proposals around that. You are right in terms of the amount of time left to deliver a lot of this is really tight. one of the challenges for us is the changing national economic circumstances since the funding was initially awarded. So we need to make sure that we can, if we progress, that we do that at pace on the basis that if we can't demonstrate progress, that funding will be required to be returned to the Treasury, and they're keen to get any money back that they can. So a lot of this is balancing multiple challenges in terms of taking proposals forward, but we still have an outline plan for the city. And bike parking, I can't answer that, but I'm happy to take that back. Oh, well, Josh.
I was involved in the early planning meetings with Turner and Townsend, the architect firm, and they definitely do all that bike storage, because that's something I said I wanted.
Thank you. Just going to ask Sarah Bennett, our legal person, to clarify something about the 15-minute neighbourhoods for us.
Thank you, Chair. I don't think it necessarily changes the point that was being made, but just for clarity, I think this is a reference to something that's in the the publication draft local plan. Get the title right. It's actually a reference to 20-minute neighbourhoods, which is 10 minutes there and 10 minutes back, generally assessed by walking or cycling. So that's the reference in that local plan document. So as I say, I think the principle of what was being discussed, it doesn't change, but just to make sure being consistent, that's the reference in the draft local plan.
Thanks, Sarah. And just to add to that, I think it's as a general matter of principle for the council. Full council did make a commitment via a motion that was passed unanimously, I think, during this year to 15-minute neighbourhoods as a general principle to underpin things. And just further to the sort of sustainability questions, just really to consider that in some of the consultation feedback here, more people were saying they would drive, and that really does go against what we're trying to achieve as a local authority, and I hope as a health authority, that should be really flying in the face of what we're trying to achieve. So the conversations about the buses and how to make that work, hopefully when we get a change of political scene in the future, because it doesn't seem like there's much going to move in the very near future, but that's, if we can be in a position where we are looking to increase use of public transport to access things like healthcare, it does need some coordination really. So it's good to hear that there's already conversations with the Mayor about that. Councillor Oxley.
Thank you, Chair. I appreciate all the concerns that people have raised within this, and they're all genuine concerns, but in general people don't like change, and people generally view change as negative, and they don't necessarily see the positives. I think for me, one of the key decisions around this is if one or more of these moves, these new bills don't go ahead, what does the future realistically look like for those surgeries that remain in their current position? And how would that impact on the local residents?
So, as I said at the beginning, these proposals were worked up by groups of practices. So, they've been worked up within the primary care networks. So, the discussions that they've had aren't just about the practices that are proposing to relocate, but about how, as a group of practices, they work together to share staff and resources and make sure they can deliver services across the network. So whilst there might be a new building, it's not just about a new building, it's about how those groups of practices in that local area work together. So Josh, as the clinical director for one of those networks, I don't know if you just want to just pick up the types of conversations you've been having within that.
I think it's a very fair question. Or I guess my first thought would, because not that this is necessarily anything to do with me, but there's clearly risks that some may not happen with everything being discussed otherwise. I guess my first thought would be, and I'm one of the practices theoretically moving into SAPA 1, so that's possibly, I'd like to think we could all and I would do this, that just because if that didn't happen, it wouldn't be great for us, it would still be better for everyone else, and so it's still the right thing to do. And the other point, which is definitely true, is at least say our surgery didn't move into a hub, but there was one of these hubs built down the road that was relatively close. That would, if that then in future had extra diagnostics, like things I was referring to earlier, or extra facilities, the way things are moving in commissioning primary care, they'd all be run through the network anyway, so they'd all be open to all the network's patients. So yes, my practice and my patients won't benefit from being in our own hub per se. Our patients would at least have access to more local community-based things from the hub down the road than having to go to the hospital, for example. So I think it would be, yes, it would mean that one practice is getting more of a benefit than the other, definitely, and I think that's realistic, but it's still some patients are getting the benefit at least. And the practices that don't move, I think it's fair to say it possibly does pose a risk to their ownership as such, but the patients at least would still be getting access to better services, and I think it's better 3 of them get it than none, if that makes sense.
Three points to add. Be dispassionate here. Sustainability of primary care is a real issue. It's a very, very real issue. It's difficult to know when and how the tipping point plays out, but I and I know lots of GPs do worry deeply about sustainability of primary care. And that has a domino effect. If one practice closes, that will have a domino effect because that adds additional pressure on other practices. I don't think we've yet seen that play out in Sheffield, but I know it's played out in other parts of the country. And carrying on risks less, and carrying on with no change does risk less coverage, and that obviously is problematic for lots and lots of reasons. As lots have said, this is capital revenue, but it unlocks different models of service, different ways of thinking, and probably unlocks more sustainable overall primary care workforce, as Josh and others have set out way more eloquently than I ever could. I'm not sure that no change is an option, or if it is an option, it's an option that comes with consequences, and we need to be mindful of those consequences. And last point from me, yes, there are definitely trade-offs here, and I think we all need to be open and clear about what the trade-offs are. But as I kind of start with where I ended, no change does have consequences on sustainability of the overall model. Change has many positive benefits. It does have some disbenefits, and we need to be clear about those. But from what it's worth, my view as a reasonably dispassionate observer is that there's a lot more benefit to this than disbenefit to this.
Councillor Lee.
Yeah, sorry, I'm new to this committee, so you might have discussed services that will go into the new hubs before, but can you just give me an outline of what would be there that isn't there already in those new hubs, and what will be devolved down, if you like, from hospital services? Because I've read somewhere that some professionals do not want to work in communities, they would prefer to stay in hospital-based. So I'm all for moving things down to a local level as much as is possible. Some things obviously still have to remain in hospitals.
Yeah, so in the consultation we were clear that we haven't developed the service model because we need to agree how we're proceeding going forward with the specific hubs, if any. We have had some outline conversations with practices about what they would see as benefits in their local areas, and with the NHS providers and with the voluntary sector as well, because you will all be aware that there isn't a definite line between health and social care and wider determinants of health. So we have had discussions around things like paediatric phlebotomy, so for phlebotomy for children, because at the moment the only way to access that is to go to the children's hospital. We know that a lot of referrals from this area don't actually end up attending the children's hospital. So we've had conversations with the children's hospital about what services they may wish to provide out in there. We've had conversations around diagnostics, not high-end diagnostics, because that takes a lot of facilities and resource. Sheffield Teaching Hospital have plans for expanding that high-end diagnostics, so but more near-patient testing and the like. So I think the next phase of design will also include firming up those service offers. and practices have a number of ideas about what they would like to see. There will be trade-offs because the hospitals also have sustainability issues, and in some ways there is a trade-off between a service model where getting everyone to attend the hospital is easy to provide, but doesn't necessarily do what we need them to do in terms of accessibility of populations. There are shortages in the hospitals as well, so trying to take some resources out of the hospitals may have consequences for them. So those kind of conversations are actively going on, but until we get to the design phase, knowing which of the centres will go forward, we haven't deliberately haven't gone into the detail of those.
So no specifics yet about what might be.
Josh might want to talk about what they've been discussing in there.
Give a couple. Obviously, none of this is formalised till the building's there and someone's doing it in it. I can give a couple of examples of stuff we've been trying to sort and the barriers we have now that will be overcome. Firstly, IAPT, that is kind of the counselling services, used to counsel outside within the surgeries several years ago now, and then moved to a centralised system. And within that time, we kind of started having more physios and pharmacists and things along those lines taking up our rooms and practices. The feedback IAPT has got about the more centralised sort of remote-based service hasn't been fantastic, and they want to move back into practices, but we now don't have the room to house them. So one of the models is they would start doing counselling in the surgeries again. We've had similar discussions with the district nursing teams who used to have a kind of a link district nurse for each practice, would work in the practice, and there's not the space to do that anymore, so they'd have local nurses based from the hubs instead. And then this is more of a hopeful idea rather than anything that could happen yet, but I don't know if you've heard of the move for what's called community diagnostic hubs, which is kind of pots of money and kind of proposals for ideas to get more lower level diagnostics in the community. And one of the biggest barriers to that is you just need a building to do it in to start with. So when I was in some meetings over summer about local potentials for that, there was nowhere to do it in our area because there's no building that could physically do it. So whilst that's not to say that this hub would immediately be able to do those things, it would at least give you a facility to be able to do them in the future and bid for those kind of things in the future, which we just can't even as a starting point now.
So just for example, physiotherapy services, you can access those in GP services, but not necessarily your own. You may have to travel to another one at the moment, but there's, it seems to me that a physiotherapy services for an area would be a must almost because of the number of musculoskeletal problems that occur for all the population in that area. I'm only using that as an example, and I'm just a layperson, so you know more about this than me. But just that, and also you mentioned counselling and mental health services. We've got a big epidemic, haven't we, supposedly, of mental health problems. Is that something, therefore, that would be absolutely vital for these hubs to specialise in as well?
On the mental health point, I couldn't agree more. And that's one that we already have the people doing the job and doing the work and having to do it remotely. So if you gave me a hub tomorrow, I'd have those staff in there tomorrow as a guaranteed thing, really. The physios is actually a very good point because that's a kind of quite new, in the last few years, role within GP surgeries themselves. We used to have to, basically any patient that wanted any physiotherapy had to refer to like a centralised hospital service with a multiple month waiting list. We now have physios we directly employ across the network to work kind of on a rota throughout the different practices in the network. And patients now can see a physio within their own surgery, usually within a week or two in our area. We could theoretically have more physio time at the minute, but we decided against it because we didn't have the rooms to put them in essence. But we do have physios in our practices at the moment. We probably could have more if we had more space. That's been a big change recently. The mental health workers from IAPT and then also the mental health practitioners we directly employ could be essentially working in the practice doing better face-to-face reviews immediately if we had the space to do it.
Thank you very much. Lucy Davis.
So first of all, there's a huge amount of data in this report, and I know how much work has gone into this from the community groups and other people that have taken part. So really just to sort of thank you for the amount of information that's here. Trying to unpick it is really tricky actually, because there's so much here, so many layers of it. And I just had a particular question about individual practices, because the information that we've got here doesn't drill down into the responses for individual practices, and I wondered what work was taking place to make sure that that had really been looked at sort of in a very thorough way, because you know it may be that sat behind this there could be one practice where actually the positive response rate is very high, but the other practice within that network, within that proposed hub, the response rate is the opposite. You know, there are a lot of people that could be disadvantaged. So trying to make a decision about a hub without understanding the picture of each individual surgery, I think must be quite challenging, and I imagine is quite challenging for the practices to get their head around. So a particular question around what work is happening there. And the other question was just sort of going back to something that's already been touched on around travel, and I think it is surprising actually that there wasn't more feedback about buses and so on in the consultation. It surprised me. Josh, you described how some of your patients sometimes are excluded from accessing services because they can't afford the travel to the hospital, for example, and we know that we're in a cost of living crisis where that is only going to be an increasing thing that we see. So I just wondered how we were going to go about sort of considering the impact where if people have to get a bus even to see their GP, never mind a secondary care service, whether or not for the people who are already most excluded from a service, whether we're compounding particularly for that group their access at an even more basic level, and what surgeries might be able to do to address that, or what we need to consider in that the whole process. I still feel like we're not, and I think Ruth touched on it, we're maybe not kind of getting to the nub of like what it means for those people who could be excluded, because there could be massive impacts for a very small group of people, even if for a large number of people there are neutral or positive impacts of the schemes, and it's those people really that concern us.
Thanks for your questions, Lucy. I think the first one about practices, I think you know that how quickly we got the report and we've got to here today. But the minute we got the first draft of this, we got cross tabulations or Excel spreadsheets answering every question for practice. So they went to each practice immediately. So they didn't they got this report as well, but they can't necessarily compare themselves to other practices, but they don't need to. They just need to see what their patients are saying. So they got an Excel spreadsheet and they could do whatever analysis they needed to do. We didn't have the time, or the company didn't, to do a report like this for a practice. So I don't know if Josh might talk about how they consider it a practice. And we've also looked at it by practice, but we're taking it hub by hub rather than looking at practice by practice. Do you want to talk about how you considered it in the practice?
Yeah, I think for us, obviously I don't know about the wider review, but I know what meetings I've been to and what things I've been given in reports and things. And obviously there was two questions to answer, if that makes sense. For us, was this a good idea for us, and was this a good idea for our patients? And as part of that, we got quite a while ago now exactly what was just described, really a spreadsheet that had all the feedback broken down by all the surgeries, including lots of comments about, individual comments from patients about our surgery, and then we got it for all the surgeries. So we got it when we were making the decision of whether we thought it was the right thing to do or not. We did get it down to a individual surgery level, and it was given to us. Patients answered on our surgery. Interestingly, I think a bit, as Councillor Mohammed alluded to earlier, most of the comments were around accessibility and wider issues in primary care, rather than necessarily the hubs themselves, to be honest, on the individual patient and around parking and things like that, which for a lot of practices would improve. But a lot of the comments on the individual surgery basis were more based on the wider issues in primary care, to be honest, rather than the hubs themselves, from looking through it when I did.
To answer your second point about transport, I think, like you, I think we were surprised that it wasn't a bigger issue, but it was an issue still for quite a significant number of people. And I think when we go through consultation and look at changing services, we look at it actually, is there a small impact on a big population or a big impact on a small population? And I think transport potentially could be a big impact on a smaller population. And like I say, it's just going to get worse with the cost of living crisis. So for the a quality impact assessment, we've pulled out all, so for the business case, we've pulled out everything in the quality impact assessment and all the themes from the consultation, and they are literally listed in a table, and for each one we're going to report about what the possible mitigation is. So that's for the consultation. And another thing we're doing in the NHS South Yorkshire and Sheffield team at the minute, actually working with Greg's team, we're pulling together a cost of living plan, and one of the problems in there that we're trying to solve is that people will not go to see their GP, or they won't go to hospital appointments because they can't afford to get there. So that's not an easy problem to solve, but there are certain schemes already, whereas, you know, if you go to the hospital and you are struggling, then you can reimburse like your bus ticket, and actually we've got the taxi scheme for the vaccines. So, you know, we are looking at the cost to see whether we can actually bolster some of those schemes to help people get to practices and to help people get to hospitals. So it's sort of slightly separate to this consultation, but it's something we're looking into because it's a problem now and it's going to get worse.
Thank you. I was going to ask specifically about the mitigations that were mentioned back in the June report that this committee received, and so there were minibuses mentioned in the equalities impact assessment as possible mitigations. Is there any sort of further news on that, whether community transport minibus style dial-a-ride type transport might actually be feasible?
So I think that is the next stage in terms of in considering what decision we are recommending. We need to look at what proposals we can bring forward to address that. So I think the revised consultation responses will allow us to build on the previous equality impact assessments and the revised equality impact assessments. So we'll probably consider that in more detail next time we bring that report back.
Thank you. I just want to probe a little bit about, you've asked us to comment about individual hubs, and I'm getting a sense that the direction of travel here might be because of the cost inflation of building potentially originally 5 hubs, I'm getting a sense that we might be looking at scaling back to fewer hubs rather than scaling back the scope and quality of 5 buildings. Is that the way that you're looking?
Yeah, it definitely is. So financial deliverability is a key constraint in terms of the project now, so we will need to make a decision. So that's one of the criteria that we'll have to look at. So the criteria, as I said, will be the outcome of the consultation, so feedback from this committee, the consultation report, the quality impact assessment, practice commitment, so how do practices feel having received their individual responses and the issues that they're dealing with, and deliverability both in terms of money and the timescales that we've got, because as Councillor Phipps noted, whilst we're trying to push as far as we can in terms of that timescales, we still have very tight constraints to be able to deliver this. And I will say again, this is a one-off opportunity that we're unlikely to get again. So we're trying to make sure we make the most of it, but we have a number of hurdles that we still need to get over, irrespective of the decisions that we make.
Thank you. And sorry, I had one more question on here as well. Well, just a small question really about, this is detail really, but a lot of people seem to have raised comments about how difficult it is to actually make an appointment. I mean, we all acknowledge that there's perhaps sometimes a shortfall of actual appointments. People are struggling and being told they'll have to wait 5-8 weeks, and we know about those issues, which are obviously unacceptable. But the slightly separate issue of when you ring your surgery and you're on hold for a long time and then it cuts you off, that seems to come up a fair bit. Are there going to be? I mean, is this part of the package of moving into a new location that the arrangements for going through reception and booking an appointment will actually be made better?
Yeah, so as part of the buildings, there will be new telephone systems that come with that. But when we move on to the next item, Abby will talk a bit more generally about what we're trying to address that problem. So we might have a solution for the hubs if they go ahead, but we're also looking at that as a wider issue.
And just finally from me, there are all sorts of considerations, obviously, as you go through to your final decision, but presumably there's some assurance that the space is actually going to be filled with the kinds of services that we need to see in the community. That's going to be an important consideration. And are you confident that you're going to get to a place where you've got that kind of assurance that we're not going to build buildings and have void space?
Yeah, absolutely, because you'll be aware that we, when we built previous buildings through the lift initiative, that was an issue. So we've done some very careful design in terms of what practices see that they could have, and we've had active conversations with partners. I think there has been quite a significant change in approach of a number of services, actually recognising the issues of accessibility and wanting to work more in communities. So if you look at the strategies of our main NHS providers, they all have a strategic move to getting more services out closer to patients. And I think the advantage of having the council as our delivery partner allows us to look at more joined up services. I think, and as I said earlier, the work that we've been doing with community groups and the consultation allowed us to get more intelligence about what would actually make a difference for those communities, rather than us thinking we've got a service over here and it'll just be easier to move it over here. So we are looking at that. So yeah, I'm really confident there's lots of people that are desperate to get out into these buildings. I think the issue will be that these are potentially 4 buildings in one part of the city. We've got lots of issues across the city as a whole.
Thank you. Any further questions? In which case, thank you. Tremendous thanks for bringing everything today and a comprehensive report. It has raised some questions, it's answered a lot of questions, so thank you for all of that. We're being asked to consider the findings as a committee, as a subcommittee, and provide a formal response on each of the hub proposals to NHS South Yorkshire by the 30th of this month. I don't feel that we're in a position to agree a response right now because obviously we've all heard an awful lot today, and I think it needs a little bit further consideration. So I'm going to recommend that we move this decision to a delegation, using the delegation function of this committee. So it will be delegated to develop and submit the formal response to the NHS. That will be delegated to the Director of Legal and Governance in consultation with the Chair, myself, but within that process we have earmarked a time for this committee to reconvene and consider some of the things that we've talked about today and put a response together as a collective exercise rather than it just relying on what I've remembered from the meeting. So if people are happy to go ahead with that as the process, are we all agreed on that? Any dissent? Raise your hand now. Dissenting? Agreeing? Agreeing, thank you. Okay, in which case, so we go ahead with the informal meeting that we've scheduled, please, Emily, for the 29th of November. That should be in all of your diaries. Thank you ever so much. I don't know if you want to, if any of you want to remain in place for the next item.
I think a couple of us are going to stay, so I'll be in.
So we're going on to receive an update on primary care in Sheffield, which this committee asked for from the Integrated Care Board. And this is really to broaden the horizon around the discussion we've had specifically on the hubs project. So this is to set all of that in a wider context of where we are with primary care at the moment, the challenges we face, and what kind of work is being done to address those challenges. Abigail, would you like to introduce yourself, Abigail?
Sorry, thank you. Hello, I'm Abigail Tebbs. I'm Deputy Director of Primary Care Contracting Digital Estates in Sheffield Place at the ICB.
Okay, thank you. So we'll take your introduction to the report and then obviously open it up to questions. Thank you.
Thank you. Yes, I'm very conscious of the time, so I won't go into a great deal of detail on the content of the paper. Just to say that what we've sought to do with this paper is just summarise some of the key issues, and I think hopefully complement some of what you've heard in the earlier paper. I think at the present times, the most pressing issues are around access, patient access to services, and the capacity of primary care collectively, not just GPs, to both respond to patient need, but also issues around patient demand, which are two distinct things, but also around how general practice plays a part in urgent care, urgent primary care, and the contributing factors to that, one of which is physical capacity of state, but also workforce, recruitment, retention, and also resilience of workforce, and general practice resilience, so the resilience of the practices and the partnerships within Sheffield that deliver those. And all of those are critical to people being able to access good quality primary care as a building block for their healthcare in Sheffield. I've also included a little bit in here around some of the immediate short-term actions that we're taking for winter to try and support that sustainability and enhance access over the coming months.
Thank you. Do Jackie or Josh want to comment any further on the report?
I think if we open it up to questions, then we'll come in and respond to that, if that's okay.
Okay. Do colleagues have any questions? Councillor Lee?
Yeah, I'm not going to name surgeries, but one of the issues that I found from my work in my area is the accessing appointments, because the telephone system is really, really poor and you're left hanging on. You get to the end and you cut off, and this happens again and again and again. And it's not, obviously I've got my own personal experience of things like that, but I'm just talking about my community at the moment, the ones I represent, and that is a big problem for patients in my area.
Yes, and we're very aware of this, and it's one of the things that comes through in the reports from Healthwatch. There are a number of practices in Sheffield who are reliant on, in terms of managing contacts by telephone, are reliant on older telephone systems that have a number of issues. One is just the physical capacity of the system, the number of lines they can create. So that's both incoming lines as well as outgoing lines for clinicians to use when they're trying to talk to patients. But also the ability of those phone systems to sort of respond in real time. So what we are doing at the moment is we've offered practices a sum of money as a grant that they can use for one of two options. One is to help them move paper records out of practice to try and create some additional physical capacity. The other, which is very popular, I think, is to help them buy themselves out of their existing telephony contracts so that they can move to a cloud-based telephone system. That has numerous advantages because it's provided on a sort of VoIP approach, so there's basically an infinite number of lines out of the practice, so Josh or whoever doesn't have to worry about waiting for a line to become free if he wants to phone a patient, or if he's doing telephone triage. The other thing is that they are far better in terms of managing call queuing. So they won't solve the problem of having to wait, but what they will do, for example, is provide functionality so that some people may have encountered it with practices or elsewhere. It says to you, you're 52nd in the queue. If you press 1, you'll get called back when you're at the front of the queue.
which means that people aren't hanging on the phone. It also means that the system is better able to cope with the volume of calls. One of the other really important things it does is it gives practices real-time information about the volume of calls they're handling, not just the volume of calls, but the number of callers. Because what we know often happens is that you've got a relatively small number of callers, but they're ringing. It's saying, you know, you're in a queue, or even worse, you get an engaged tone, they're hanging up and ringing back again. I had quite a good example from one practice a little while ago who had, in a 1 hour period, they had over 1,000 calls, but when they actually looked at the number of callers, it was 75 callers. And it helps you then understand some of the stuff you don't understand about demand, because I know practices at the moment feel that they're facing this tsunami of demand, but it helps to contextualize that. And there are different ways of dealing with 75 callers to 1,000 callers, and it helps you plan your systems and processes better to do that. It can also show you how many drop calls you've got. It lets you put real-time messaging on, so you can say, I'm sorry, we've got a lot of calls at the moment, if you can ring back. One of the other important things it does is it serves as an enabler. We've been talking a lot about how practices can work together and networks might want to work together in the future. And having digital telephony is a key enabler if practices want to look at approaches to managing calls, either on a day-to-day basis or at times of great pressure, by coming together, for example, to provide, you know, a virtual call handling centre and triage in that way. It gives you the functionality to do that, which practices just don't have at the moment. So in and of itself, it's not a solution. It doesn't give you more staff, but actually it should be helpful to both patients and staff in terms of reducing some of that frustration, which also hopefully then tips over into some of the other things practices are experiencing around difficulties meeting patient expectation, violence, aggression, abuse that particularly reception staff are facing on a day-to-day basis. Is there anything you wanted to add, Josh?
Yeah, thank you. Just really to say from an experience of it, we got a funded move to that type of phone-based service, I can't remember when, relatively recently, and it has been exactly as Abby describes, in every way better, really, in short. The other thing it's allowed us to do, ideally what we want is more reception computers, more reception phones, a bigger reception and more receptionists. That would actually solve the issue, but it would require a lot of extra money on a long-term basis. What this at least has allowed us to do is we can now get like really good data of when we get exactly how many calls, for how long, how many people are calling and what they're calling for, that kind of thing that's very live. And what it's allowed us to do is rejig our reception rotas to more accurately staff reception. So we don't have more staff, but we can use them at better times, if that makes sense. And we've done that based on the data we get from that phone system, which is, it's not solved the issue, but it's definitely made things easier.
Just a comment, the callback system is good, and people will have confidence in it as long as, you know, as soon as they realise they do get called back, and I'm sure you will do, that will happen, but, you know, you do need confidence that things are working, don't you, before you'll be happy.
You do, I get that. It's a bit of a leap of trust the first time you might do that, isn't it? I know it was with my practice when they introduced it. You know, if I press one, am I actually going to get the call back, or would I just be better hanging on? But yes, I think once it's demonstrated that it is robust and it does work, then people will have that confidence, hopefully.
Just on that, is it possible to have a picture of, I know you're saying you don't always know how the number of calls directly correlates with the number of people calling if they're hanging up and recalling. So, albeit that's a difficulty in analysing the numbers, is it possible to get a realistic picture of to what extent demand for appointments is greater than capacity of appointments at the moment? What sort of position are we in, and is it on a trend that's getting better, worse, staying the same?
The only thing I can tell you is that demand is demand rather than need, and I'm using that advisedly, is significantly higher than the number of appointments, but that is all anecdotal. there is no accurate way at present of measuring demand for general practice, for primary care appointments, unlike secondary care, because it's at the top of the stream. So anything that doesn't get through isn't captured. Whereas, you know, obviously you've got waiting lists, you've got numbers of referrals and waiting lists once you get down to secondary care. All we can tell you with any degree of accuracy is about the number of appointments that are offered and filled. The other thing we would hopefully be able to do once we've got the majority of our practices on cloud-based systems is work with the practices to get that reporting of number of callers, which would give you a proxy. Even that wouldn't necessarily be accurate, but it would give you some kind of a proxy for demand. So that's another reason why we're really keen to get practices onto the up-to-date, onto modern telephone systems. Yes, sure.
There's something we're doing locally to try and answer that for our own practices, just for our own benefit, but it's proven to be a lot of work, and how you scale that to a wider system level, I really couldn't even begin to think, to be honest. The difficult consideration, I think, in primary care is most surgeries operate a system where you have a certain amount of appointments offered a day just because there's that many staff there to do them, and then you have an on-call GP who basically will pick up anything extra where the patient's contacted the practice and they've been told there's no appointments left, but they sort of declare their problem to be urgent in whatever manner, so they kind of get put through to the on-call triage list. So we can quite easily see locally what we offer versus what we do, and what we do is always more than the initial offer for that reason. And it does that. As Abby said, demand is definitely increasing, and if you look at the amount of the gap between originally bookable appointments and then work actually done on top of that is definitely increasing, which obviously isn't what we want. But I think if you look at data nationally and locally, the amount of actual GP appointments being done is going up massively year on year, actually, and a lot of it is ended up being done in that kind of urgent extra type section, really. So yeah, how you solve that, I don't know. In short, but you can look on a local level the difference between what you offered versus what you actually did, and that gap is definitely increasing. As Abby said, I think doing that on a system level would be a massive challenge, because what it doesn't give you is the patient who rang and said, I want an appointment, and they got told there's none today and the next one's in 3 weeks or whatever. They understandably weren't happy with that answer, but their problem didn't require an actually urgent callback today, so that patient gets lost from the system, and I don't think there's any way you could truly represent that data, unfortunately.
Can I just ask a really cheeky question, like a yes or no question? Are there enough appointments?
I think it's really difficult to say. What do you think, Josh?
I'll be as political as I can with the answer. There's two. You can answer yes and no in one way. For need, yes. For demand, no. Is the way I'd look at it.
And is there? Would you say there's a correlation of diminishing healthy life expectancy with difficulty in accessing appointments? Are those two things tied hand in hand, and also the health inequality that we see across our city?
We were talking about this morning. The increasing health inequality and increasing social problems, to want to use that as a better term, I think is a massive driver of the increased demand in general practice. Basically, if you look at pre-pandemic, I'd say the majority of my surgery was people with medical problems that needed a medical solution, to put it in a simplistic way maybe. Now a significant proportion of each surgery is people basically who've been declined PIP and want a letter to kind of reinforce their PIP appeal, for example. People who are on universal credits because they can't find work, and their job advisor, at least according to them, has advised them to come to see us to get a sick note because it'll be better that way. Well, give them more money to live off, basically. People who are the amount of sort of lower level type mental health appointments I get now compared to before COVID is not comparable, to be honest, the difference. So I think the increase in demand, and this is very much anecdotal from my experience, but I think a lot of my colleagues would agree, a lot of the increase in demand is essentially, I don't know a word like this, but primary care trying to absorb issues that have been maybe caused by other areas of the system. And obviously primary care has its own role to play and its own issues as well. I'm not trying to say that for a second, but a lot of my appointments are more around people's housing, people's benefits, people's access to food, people's basic needs of life, more than they are around an actual primary medical problem, I'd say.
And I think that's one of the reasons, one of the projects that we are working on, it's starting in a small way, is around what we can do to what we can create that wraps around general practice, that uses community resource, so voluntary groups, not necessarily larger voluntary organisations, but community groups, voluntary groups, how we can support them working with colleagues in the council, and that gives that resource that GPs or practices can refer patients into. We've also just had looking at what we can do with citizens' advice as well to try and help support some of that in the short term over the winter, but then going forward in the longer term, how we can train people, train social prescribers and others to provide some of that advice that we know people are seeking from practice because they can't find it anywhere else. And that then frees up clinical staff to do the things that clinical staff only can do.
Thank you. I've got Councillor Howard and then Councillor Lee. I'd like to ask Lucy to make some comments from the Health Watch perspective, and you may have some questions, and then Councillor Phipps. Right, got a queue. Councillor Howard.
Thank you. Really interesting points there. Just some quick questions. I couldn't see anything in the papers about whether the apps are going to be improved so that some of the standard things that people call for can just be either downloaded from their app or maybe book sort of appointments. I'm not sure if we're that advanced yet where we can book appointments via an app. Are there any particular pieces of work happening to improve reception facilities as well, and the reception staff who are often diagnosing how urgent some appointments are and how not urgent some appointments are? And I think sometimes that can be really frustrating for members of the public who think they're dealing with somebody who's not clinically trained to assess whether they should get an urgent or non-urgent appointment. So is there anything happening there in terms of training for those members of staff, and could that be mitigated perhaps with a centralised telephone system where you do have better trained staff who could decide, similar to an ambulance service, but decide whether people's health problems are requiring an urgent appointment. And I had a member of a resident in Firth Park who was told that she'd get a call back in 6 weeks for a cough that she's had for 2 months. And I would say that somebody that has a cough, and I think the NHS advice online is if you've had a cough for a certain amount of time, then actually you should get urgent advice, but the receptionist didn't deem that to be urgent, and so she's still awaiting a phone back. So is there anything that's happening with that area of work in terms of improving the quality of access, initial access, and then the online app support as well for people that can use it? Because I'm clear that not everybody is accessing online apps as well.
Thank you. Yes, and there are a sort of multiplicity of online offers now. The NHS app, which is a national app, that's out of our control. Within South Yorkshire, we are looking at how we bring together the functionality of the NHS app and various other online approaches. That piece of work is ongoing. I think when it's a little bit further advanced, it may be helpful to our colleagues who are working on that to bring something here to talk to give you some information on that work. It's called Digital Services for Our People. So I think that would be helpful. There is some communications planned nationally around awareness raising for different forms of consultation, so video and online consultation. And we are working with practices now in advance of that to make sure that their approaches to digital and online consultation, the visibility of it on their websites and so on is as it needs to be to avoid any frustration if people pick up on that advertising and then can't access those services. But they aren't without difficulty themselves. We aren't at the moment looking at anything to build on the standard NHS app ourselves because of the digital services for our people work that's going on. But we will get, I think it would be helpful if somebody came to give you some information on that. In terms of receptionists, they are really key, reception staff are really key to how well practices function. And receptionists do quite a lot of filtering and direction of calls, but they won't be making clinical decisions. They will be picking, they may ask people what their issues are, but that's so that they can triage them, to a first contact physio, for example, if it's a musculoskeletal issue, rather than a GP, which is much the best place for them to go. We did some awareness raising around the range of roles within general practice and why people like receptionists might ask you questions that you feel are about, your medical condition. Last year we recorded a number of videos and did some publicity about that as part, I think, of our sort of winter campaign this year in terms of trying to support people to choose well. We will revisit some of those to help explain that. We have put quite a lot of support into providing training for reception staff to improve recruitment and retention. We're also piloting a training approach with the Primary Care Workforce Hub in South Yorkshire for reception staff, because there isn't a very career path in administration in primary care, and we know if we want to grow high quality admin staff in primary care, we need to be looking at that. So that is a piece of work that we're doing at the moment. Josh, would you like to say anything about the?
It's a difficult one, and I'm not going to pretend there's a straight answer, and any system will have flaws and any system will have things that don't go as well as they should. You really do need some elements of triage when the person rings the practice, and that goes back to what my answer to the earlier question is. We probably have enough appointments for the need, but certainly not for the demand, and what we have to do our best is direct it towards the need rather than the demand as best we can, at least. That won't always work perfectly. I think at face value the idea of a centralised line with training might seem good. I'll be diplomatic. Anytime that's happened, patient and clinician feedback has been poor and it's gone back to being done at the practice. I'd probably rather get triage than one of my receptionists than my 111 if it was me, being not too political. But I have more faith in my receptionists, shall we say. So may as well give a straight answer. They do have more training and experience than most people realise. I agree, waiting 6 weeks to be seen or spoken to even about 2 months of cough is not right. And any system won't always be perfect. I think the short answer, I don't think there's necessarily a problem with the current model. You just need more of them, is the honest answer. And again, that's not facilitatable in a world without unlimited money, realistically. But the whole reason receptionists ask and get a lot of training around this from us and from sort of external health bodies, the whole reason they ask that question is to try and direct our appointments towards the need rather than the demand, and that will lead to upset patients, understandably, but it will hopefully lead to more of the right patients getting the right care.
apologies, Chair. Myself and Dr. Meek do need to leave now, but we can leave you with Abby, if that's okay. And thank you for all your
Thank you very much indeed for attending and all of your input. Thank you. Thanks. Who was next? Mary, Councillor Lee, I think your questions.
Well, I think my question was going to be about low-level mental health issues and whether they ever reach the level of a clinical diagnosis, but I think we're going to have to miss that one, because unless you can answer that one. And so we get...
Or we can bring something back if that's helpful. I can send something in.
Yeah, I think it would, because low-level mental health problems, there's an upsurge, compared to many, many years back. And what is that due to? Is it that due to societal changes, differences in lifestyle? What is causing that? What is helping? Why are people developing these problems and and think they've got to go to GP to solve the issue? So are they reaching the level of clinical diagnosis? And if not, obviously you mentioned social prescribing, which I think is really important, especially if somebody is maybe a certain level of depression. But what can we all do, us as a council, given our limited resources? The voluntary sector needs to play a big part in that. So yeah, I would certainly welcome a report on that whole issue. I think regarding those low-level issues that come to GP practices, and sometimes come in the form of not mental health. People don't come saying, "Oh, I'm really depressed," or they might come in physical symptoms that people might experience. So yeah, I'd welcome that.
I'm happy to take that back. I hesitate as a non-clinician to to give you my views. I mean, I think it's multifaceted, and a lot of we know that COVID's had a huge impact on the number of people presenting with mental health issues in practice. And similarly, we can anticipate the cost of living crisis does similar. And as Josh said, we see so many increasing numbers of people who are, as you say, coming forward and either presenting with physical symptoms or depression, but as Josh explained, actually some of their actual fundamental underlying problems are social or economic rather than clinical. So yeah, I'm happy to take that away and ask if something can be brought back to the committee.
I would like to welcome Joe Horrobin. So we haven't got a name card for you, Joe, if you want to introduce yourself. Thank you.
Yes, thank you. I'm just sort of leaping in opportunistically. Joe Horrobin, Director of Integrated Commissioning at Sheffield City Council. And I'm just jumping in because I think it'd be a really useful piece of work for me to do with Abby and with our various colleagues in this integration space, because this is certainly an area where if we can work better collectively, and when I say we, I mean the voluntary sector as well, I mean education as well, and I had a very live conversation about that yesterday with head teachers from locality B in the city, talking about how can we work differently and better together to address the pressures that are across the system, because it feels as though everybody's coping with everybody else's failure demand as well as their own failure demand, and there's no easy answers to this. It is long-standing and systemic, and it's exacerbated for individuals and for organisations by the financial context we all find ourselves in, whether that's households, individuals or organisations. So I'm just throwing my hat in the ring really to say I think it would be a really valuable piece of work, and the council currently has a strategic review underway of our council early intervention and prevention model, and we are just on the cusp of sharing our internal findings about our own services and commission services with colleagues in the voluntary sector and with colleagues in health. So it feels like a really opportune moment to come back with something together.
Thank you for that. And I think if Councillor Lee might want to if you might want to put your question down in a written form for us. And thank you, Abigail, for offering to take that up. And I think we have got space in our January meeting to hear a bit more about this and perhaps receive a report back at that stage. And I think we'll be receiving a report from the CAMS service regarding the CQC progression. So that would tie in nicely with our work programme for January. Thank you. I'd like to ask Lucy to briefly comment on some of the feedback that Health Watch has been receiving on primary care, and then Councillor Phipps, and then I think we're heading towards the end of the meeting, so we'll take those and then see where we are with time.
Thank you. I know we've not got much time, so just to sort of highlight that we did circulate what was essentially a kind of compilation of our feedback on GPs throughout the year. So I don't know if you've seen our monthly insight reports, but each month we publish a kind of what we're hearing report, which covers not just primary care, but all services that we're getting feedback on. Unsurprisingly, every month without fail, we do have quite a lot of feedback about primary care. It's always there very prominently in the mix. So the sort of informal report that we pulled together was essentially a copy and paste of each of those sections. From each month throughout the year, you'll see there's quite a lot of positive feedback in there as well. Still lots of positives around people's experience of care once they're able to access it. But as the conversation's already described today, the sort of barriers to access in terms of phone systems, appointment systems, are huge for people. And I think if you look at the GP survey data, which is fairly recently been published, we know that nationally in South Yorkshire and in Sheffield there has been a steep dip in satisfaction. The public satisfaction with GP services, very noticeable dip in that. So I think the sort of poor experiences that people are having are really real, and people are having a very, very difficult time accessing primary care. I feel, this might be slightly pedantic, but I feel slightly cautious about us trying to separate it out in terms of need and demand in that way that you were describing, because actually for those people that are trying to access primary care, it may not be what would be classified as a medical primary care need, but the need is very real. And I think we just need to be careful not to sort of create a picture of actually people are demanding when they don't need to, because I don't think that that is what is driving the situation that we're seeing, and for GPs that are struggling to offer care and the patients that are struggling to access it. It's two sides of the same story, which is about inadequate resource and systems that are just not designed and able to meet people's needs. I'd only highlight within that as well a sort of particular concern from people that maybe are more excluded because they are less able to navigate the system, which has become increasingly in many places that you need to phone at a certain time, you need to be available to take a call back at an unspecified time sometimes, and I think there is a big group of people who have become more excluded. So I think it's not just a question of experience has dipped, but I think, and this is only based on the anecdotal information that we have, but I suspect that that is not an equitable dip. It is actually far worse for some people than others. So that's the slightly rapid summary of kind of what we hear. It's really good to hear about some of the developments around the phone systems and so on, which I didn't know about. That's really good to hear, and we'll certainly be looking out for any feedback that helps us understand how impactful they're being.
Thanks, Lucy. I think I've got particular concerns reading the monthly reports that there are things that stand out for me, like people with autism saying they're unable to access the appointments they need because of the phone systems. And that's really a very serious consideration, I think, that needs looking at systemically about how people can be unable to access. Not that one person should be able to jump the queue ahead of others, but that there's adequate route in, really, for people who can't navigate these complicated phone systems. There was something as well that really struck me in these reports about people hanging up from a call. And I mean, we hear the same story with people people calling the police number and hanging up, and we just then don't know actually what it gives us a picture of demand, but it means that we don't know actually what need is out there if we're not actually receiving the phone call. So I think they're things that really do need digging into quite urgently. Councillor Phipps, you've got some questions, and I think we're just about running out of time, so I think you'll be the last.
Thank you, Chair. I have a comment and a question. I appreciate the time, but I was wondering if we could quickly invite James Martin to come back around the table just to ask a question or two around the appointment booking availability and potential blackouts as well, if that's okay.
Thank you. It's just with mention of changing phone systems to a cloud system, one of the issues I've been tracking through for potential extra impacts on disabled people is if the nation has to encounter rolling 3-hour power cuts. Now, if it's a cloud-based system, I think there's some extra questions about how resilient GP access and so on will be in that situation. So I don't know whether that's something you have an answer for now. I had a feeling your colleagues who've now left might, have known more. But I think we hope there won't be this issue of rolling power cuts. But I think, there needs to be some thought because of the extra strain it will put on services if there aren't backups in place.
Yes, there is, obviously we're aware of the potential risk, and there are planning, there are discussions ongoing about how we would prepare for such an eventuality. I'm not wanting to suggest that we're aware of anything that's happening that anybody else is, but obviously it's as well to have some of those initial conversations and start thinking about preparedness. It does present a challenge for, I'm talking specifically about primary care, it presents a challenge for primary care. The telephony, to be honest, is probably the smallest challenge. I think regardless of whether it's cloud-based or otherwise, once the power goes, the telephones cease to function. But the greater issue is about, greater issues would be around access to clinical systems, because obviously they would all cease to operate as well. There are ways around that if you know in advance what patients you are. There's ability to download things or print out clinic lists and that type of thing. So there are ways around it if you plan in advance, but there are other considerations as well, like for example refrigeration for vaccines and that type of thing. So there were a range of considerations that we'd have to take into account if we were getting to the point where that was a likely prospect. Yeah.
Thank you. Thank you for your contributions today, Mr. Martin. I hope you'll remain engaged with this committee because you've brought some really valuable insights and questions for us. Thank you.
Thank you, Chair. Really appreciate that. So it's good to hear generally about the improved cloud-based phone system. I think that does sound like a step up. But I really agree with colleagues that it's really difficult to get GP appointments, really difficult to book them. Personally, the last time I tried to get an appointment at my GP, I was unable to after a few days of trying, maybe even a week. Ended up speaking to 111. They triaged me to a pharmacist who couldn't help me. And then I ended up going to the walk-in on 2 separate occasions because the first time I went, the queue was over 3 hours. It was a Friday evening. It probably wasn't the best time to go, but it was when I needed to, so I did. So I just thought I'd mention that as a personal experience, and even if you know the system well, it's still really difficult to get an appointment. And then my question was just a thought really around what the impact of Brexit's been on GP availability and on GP recruitment. Because I know a lot of our healthcare system is supported by workers from Europe or outside of Europe as well. And I know figures have shown a decrease in the amount of healthcare workers coming from Europe in particular. And I was just wondering the impact, if what we've seen from the impact of Brexit on GP availability? Thanks.
In terms of the impact of Brexit, I'm not sure I would be confident to say yes or no, particularly at a Sheffield level, and that's not sort of trying to skirt the issue for political reasons, but the issues are often a lot more, I mean, a lot of the issues are around the number of staff who are trained, and staff who wish to work in general practice, and particularly in general practice in more deprived or more challenging practices, as we discussed in the previous item. And what our practices are telling us at the moment is, obviously, there are, in the face of the pressure that general practice is under, there are GPs who increasing numbers of GPs who may be choosing other routes, so maybe not patient-facing general practice, or maybe a more, a more portfolio career with a range of different roles, or looking at the option of just becoming a locum, because then you can, you can choose when you work, and you can choose which practices you work in, and you can also choose how much you wish to be paid for that. And certainly, one of the difficulties our practices are reporting this year is around increasing costs for locum staff in practice as well, which is just adding to compounding the underlying issues. In terms of access to appointments, we have talked about that previously, and I think acknowledged that it's really difficult. That in part is why it's so important, I think, to get messages across to help people to help people make a decision about whether there are alternative services that could support them, whether 111 could or the pharmacy could, just in order to try and reduce some of the, I mean, it didn't work in your case, obviously, but, just to help try and get people to the right place as quickly as possible. We also have enhanced access, obviously, which, in terms of the flexibility of appointments too, now offers appointments between 6:30 in the evening and 8 o'clock in the evening, Monday to Friday, and 9 till 5 on Saturdays. So hopefully picks up some of those people for whom a daytime appointment isn't appropriate. Those appointments are pre-bookable 2 weeks in advance, so that should also give some flexibility.
Thank you very much, Abigail. Appreciate your contributions today and for staying for the duration as well. Thank you very much. So, colleagues, we're asked to note the report on primary care. So thank you to the ICB and the officers who have prepared that, and that's noted as a committee. Yeah. And then it just remains for us to agree the work plan, the work programme. So, as noted in Appendix 1 in the agenda pack, that we note that we agree the work programme as it is, and that we give consideration to any further issues for potential addition to the work programme. And we've already mentioned a couple of items that will be coming probably to the January meeting. Any comments?
Just ask a quick question, Chair. I'm getting confused between this meeting and the adult health and social care agenda. Will the hospital's report, will that come to this meeting or so at the last meeting, I can't remember, was this one or the adult health and social care, when they came with their RI inspection report and update of what the hospital's Jessops is doing? Is that coming here or the committee?
That came to the last meeting of this Health Scrutiny Subcommittee, and we didn't ask for them to come back within a particular timescale on that. So if you wanted it to come back here, this is the committee that would look at it, but it isn't currently on the work programme.
Okay. I thought that they were going to come and give us an update on how they're getting on, not immediately, but in 6 months' time. I think in relation to Jessops in particular.
If the committee wants to include that on the work programme, we absolutely can. But I don't think we captured that at the last meeting.
Yeah, I think that would be useful to get to us for a report back on that. Thank you, Councillor Mohammed. Okay, so with that in mind, are we all agreed to accept the work programme with those additional items? Thank you very much. And that is the conclusion of our meeting today. Thank you very much, members and officers, for your time and contributions.